Hello and welcome to MedEvidence Articles, where we encourage community research and education with weekly articles. I'm your host, Benton Loeyball, and this week we're talking about episodic and chronic migraines. Migraine vs. Komodo dragon, a battle of headache proportions. If headaches are like an iguana, migraines are a Komodo dragon. They're bigger, badder, and hurt a lot when they attack you. Migraines are very common, affecting about 1 billion people every year, and unlike Komodo dragons, they affect people in every country, and the number of people who experience an attack increases yearly. Migraines are classified as primary headaches. They're not caused by another underlying condition, and come with at least 2 of the following criteria: pulsing or throbbing, predominantly affecting one side of the head, pain that is moderate to severe, worsened by or requires avoiding normal activity. Additionally, migraine headaches are accompanied by one or both of these symptoms: nausea and or vomiting, and sensitivity to light and or sound. On the MedEvidence podcast, Dr. Stephen Tenges explains that not all of these symptoms are necessary to diagnose a migraine.
The person does not need to have nausea. You don't need to have light and sound sensitivity. As a matter of fact, it's even possible to have a migraine and have no pain.
Additionally, many people experience an aura, which is a disturbance of our senses, speech, muscles, and or vision, kind of like a Komodo dragon bite, that often precedes a migraine. Migraine frequency, episodic versus chronic. Migraines can be differentiated by how often you get them. Episodic migraines occur for fewer than 15 days a month. This could be a few per year, all the way up to every few days. Episodic migraines can get better, called remission, stay the same, or get worse. Much like venomous lizards, a few migraines are bad news, but if you get too many, you have a real problem. Chronic migraines are frequent or constant migraines, with or without aura, that occur for 15 or more days a month. That's at least half the days of every month being a headache day. Chronic migraine is somewhat rare, but the definition changed around 2018, which makes exact numbers difficult to come by. Like all migraines, chronic migraines primarily affect women. Around 25% of chronic migraine sufferers go into remission each year and are downgraded to an episodic migraine classification. The other 75% of people with chronic migraines either have stable or worsening migraines and are often dissatisfied with their treatment options. Many find their condition debilitating or disabling. Understanding migraines. Migraines are complex and the exact mechanisms are unknown. Several research studies have investigated causes, but since we can't ethically give people a migraine to compare it to a placebo in a randomized controlled trial, it can be difficult to find definite answers. One theory is that the brain becomes sensitized to pain. Sensitization to pain is when the threshold for pain lowers, making normal things feel painful. When you're sunburned, for instance, your skin is sensitized to pain, which can make things like high fives, lizard claws, and even clothing hurt. The theory states that pain signaling neurons are sensitized, making you feel pain when there's no real problem. Some of the risks associated with migraine include being female, genetics, obesity, metabolic syndrome, depression, anxiety, and stress. On top of this, many people have triggers that initiate a migraine. These may include specific foods, noises, sleep problems, weather changes, and more. Treatment options. Targeting risk factors. Addressing risk factors like obesity, depression, and stress may help. Additionally, identifying and avoiding triggers can help stop migraines before they start. Abortive medications. Abortive medications are designed to rapidly end or abort a migraine. Analgesic medications like aspirin or ibuprofen can lower the pain for some people. Other people need migraine-specific medications like triptans or inhaled dihydroergotamine spray. Unfortunately, poorly controlled episodic migraines can significantly increase the risks of developing chronic migraines. Overusing these medications for more than 15 days a month of analgesics or more than 10 days a month of triptans can increase pain sensitization. Ironically, underusing medications for episodic migraine may increase the number of attacks. Clearly, quality care is critical for chronic migraine mitigation. Preventative medications. Abortive migraine medications are important, but not the whole story. Preventative medications help stop migraines before they start, but require regular use and may have side effects. Randomized clinical trials have found that some preventative treatments, including topiramate, are effective for chronic migraine, though only around 1/3 of sufferers use them. Botox is another approved option for chronic migraine, but not episodic, though its cost can be a barrier for some. There are other treatment options available, with more being investigated through clinical trials. If you are experiencing migraines, talking to an experienced professional is the best way to ensure that care options match your specific needs. With the help of quality care and new medications, we might be able to make migraines as rare as the endangered Komodo dragon. Thanks for joining us on this week's episode of MedEvidence Articles. If you'd like to know more, all of our descriptions are linked in the podcast description below. You can also visit our website at medevidence.com. MedEvidence helps answer the question of who can you trust for medical information. The MedEvidence platform provides valuable information about many medical issues and the insights of evidence-based medicine. MedEvidence educates audiences through engaging and entertaining magazines, podcasts, videos, articles, and presentations. We strive to bring together diverse voices of top-level medical professionals, researchers, and experts to provide unique and engaging content that uncovers the truth behind the data. For more great content, including discussions by physicians and subject matter experts, check out the MedEvidence podcast. My name is Benton, and we'll see you next week.